Hi, my name is Tonya Taylor, and I'm a medical linguistic anthropologist. I'm also faculty in the College of Medicine and the Division of Infectious Disease and the STAR program at SUNY Downstate Health Sciences University. But I'm really proud to also be one of the co-directors of Bridge, the Brooklyn Initiative to Develop Geriatric Education. Today, it's my pleasure to provide one of our SLMs, our self-learning modules entitled Cultural Humility and Implicit Bias in Geriatric Care. But first, we have to acknowledge with enormous gratitude our funders, HRSA, the Health Resources and Services Administration, provided us with two large grants that will enable us to develop this really important curriculum, be able to disseminate it, as well as also reach out to older adults throughout Brooklyn and help provide them with information about geriatric care. I have no conflicts of interest, but this is where we like to start all of our SLMs talking about an age-friendly healthcare system and the 4Ms framework. But as an anthropologist, this time we're going to focus on those aspects of culture that also intersect with the 4Ms. So in addition to thinking about health outcomes and goals and care preferences so that we can align individuals' care with the older adults, we also want to understand what matters to that older adult because they can be facilitators or potentially barriers. So we want to know if family is important, if their community is important, maybe their spiritual center really important. And these are factors that we take into consideration when we're trying to develop that care plan for that individual. Medication, it's extremely important as we get older, mostly because of the risk of polypharmacy. But also we focus on medication because sometimes medicines can impact other ends, such as mentation or mobility. And so it's really imperative that we focus on medication. Mentation is basically mental health and our brain health. As we get older, our brain does decline naturally, but sometimes our brain does not decline naturally, such as Alzheimer's. Also, there's mental health. I feel like these are two aspects of aging that have real cultural underpinnings in terms of how particular communities think about mental health or how they define or even think about Alzheimer's or dementia. And then finally, our last M is mobility. So for that older adult who really enjoys going down to the park and doing salsa every Saturday, maintaining mobility is really important to their life. And so we also focus on physical function and how individuals can maintain and sustain independence and autonomy. So these are the other self-learning modules in Group A, comprehensive geriatric assessment, wellness and functional ability, interprofessional teams and care of older adults, the age-friendly healthcare, the 4Ms, dementia-friendly communities, geriatric syndromes 1 and 2, and cultural and linguistic competent healthcare of older adults. Our last one will be ageism. These are some commonly used acronyms throughout our SLMs. However, I don't really have a lot of them in this particular presentation. Our learning objectives for today include that I want you really to be able to define culture and cultural humility and understand how they impact the clinical encounter. I also want you to understand what are the 4 stages of learning and the impact of implicit bias on care and clinical outcomes. We will also discuss 3 enhancement tools or models to help us hone our cultural humility. And finally, I'm going to share with you 10 strategies that will help anybody right now to improve their cultural humility. But before we get started, we have our ageism alert. I love this image of this wonderful woman who's dressed spectacularly doing the dab. So ageism is defined as a systematic stereotyping and discrimination against people because they're older. And what is really tricky is that ageism in healthcare is everywhere. It permeates the attitudes of medical providers, the mindset of older patients, and even impacts the structure of our healthcare systems. Hence the need for developing an age-friendly healthcare system. So we're going to start with defining culture. And I know everyone thinks that they know culture, and perhaps really do. But this is an opportunity to also think about culture of an older adult. Before we get started, I want you to just maybe pause and try to think of how would you define culture? What factors are commonly associated with culture? And how does culture impact the delivery of care? So you can pause and then come back. As an anthropologist, this is a definition over 20 some years that I've cobbled together. It's basically sort of a definition that is primarily focused on the fact that culture is cognitive. Having culture is the lens that helps us cognize and understand the world. And I'm a huge proponent of thinking about culture being cognitive. We define it as an individual's patterned ways of thinking, feeling, and reacting that are socially learned and shared by members of a group. Let me emphasize one thing here. Socially learned. We learn culture from members of our community as babies, as adolescents, as young adults. And the thing is that our culture is shared by members of our group. It is indeed the social legacy that we are given from our communities. But more importantly, it is about identification, how we see ourselves. Now, culture is not static. Within groups, there's a lot of diversity. So it's not homogeneous, but still, the boundaries of culture, there's still something that is shared. There's still patterns that are similar. And this is what we call culture. I also wanted to share a wonderful definition of cultural diversity, which is ultimately what we aspire to, a real celebration of all of our cultures and our unique and diverse ways of thinking, feeling, and being in the world. So this definition describes culture as the combination of the ways in which each of us is, like all others. As an anthropologist, we're all Homo sapiens sapiens. We are similar. We have the same historical ancestors from Africa. But yet, we are like some others in terms of our group cultural identity, right? And then finally, down to the individual level. And we are like no others. So we are like all others in terms of our connection to humanity, like some others in terms of our being connected to a cultural group that shares something that is distinct from others. And as individuals within these communities, we can also There could be a wide range of diversity in terms of how we interpret our cultural legacy. So these are some standard cultural identifiers. I think that for most people, you would immediately run to these identifiers, race, and color, and ethnicity, or nationality, language, accents, spirituality, religion, gender identity. For a lot of these, they're on the surface, and what we like to call the waterline of visibility. These are some of the things that we can see, and we are able to make assumptions about people or stereotypes or generalizations based on these visible cultural aspects. In the upper right-hand corner on this iceberg, the tip of the iceberg, is age. Age is seldom really considered when we're talking about culture, but age is very important. As you can see, age and life stage, I put here in the center as another aspect of culture that we have that might be visible, but there's a lot of stuff that's invisible. Sometimes it's our physical ability. One of my best friends is hearing impaired, and you really wouldn't know that she was impaired because she can speak and she can read lips. Political affiliation, you can't look at somebody and know what their politics are. Work-related variables, not everyone's walking around with a little badge saying, I'm the boss. Appearance and attractiveness. Believe it or not, this is a really tricky aspect of culture because often there is this normative value of what is beautiful or what is attractive. And here, these norms often infringe on cultural notions of what is beautiful, whether it's sort of big lips or a different, body type. These are things that are shared within cultures. Sexual orientation, social or thinking style, whether you're an introvert or an extrovert, your educational skills or talents, your family relationships. Are you the firstborn or the baby in the family? Your values, your views. These are all the sort of intangible things or aspects of culture. Culture, as we mentioned before, in terms of views, also includes our worldview. Our worldview is the bigger picture in terms of how we understand the world and people in it. Culture also includes social organization. We organize our societies different. In Philadelphia, in an emergency room, some doctors were really surprised when there were all these people showing up to find out how their loved one was. And they sort of said, oh no, we just want to talk to the family. But the family included everybody, and they all needed to be considered or talked to in terms of considering what steps were going to be taken for their loved ones, instead of it just being the Western notion of a nuclear family. I should also say, in terms of social organization, that maybe some cultures privilege the voice of an older man, where in some cultures, they privilege the voice of the older woman. Perceptions of space. This is a big one. Some people really don't want to be close, and we have to respect that. With an Orthodox man, I will never try to shake their hand because I understand that that would be inappropriate. Time orientation. This is the clock here from Zimbabwe, sort of showing the funny different aspects of time in Zimbabwe. So Western time was now. But if someone just said just now could be 5 minutes, or 5 hours. And so understanding that culture also has an impact on notions of punctuality or lateness. Communication practices. As a linguist and an anthropologist, I think language is the most important vehicle in terms of how we understand each other and understand how we cognize the world. And finally, there's some really amazing sort of biological variations. For example, the people who live in the Andes in South America, they've developed over years and years of living at such a high altitude, this amazing ability to not get tired when they're high up on the mountain. And they just keep walking. And when I was hiking the Inca Trail, I was 25 years old and I couldn't keep up with this 50-year-old guy. It was really quite amazing. But culture can also really specifically impact our beliefs about sickness and disease. In some communities around the world, there's um, there's medical pluralism where individuals will use different systems of health and healing. So, for example, in Zimbabwe, most people will go to a Western doctor, but they will also go to a traditional healer. They do different things. And, a traditional healer might prescribe some medicine, some herbal roots, or something to help with chronic diarrhea, something like that. But then they also help explain why misfortune happened. The most important aspect in terms of culture and sickness and beliefs and views about sickness and disease is that often it delays engagement in care and treatment. In Zimbabwe, one of the doctors was quite aware that all of his patients would go see a traditional healer, either before or after. And sometimes he would, especially when it was HIV related or with tuberculosis, he would sort of say, this is what you need to do. Go see the healer right now and come back. Because he understood that if he acknowledged that he saw other healers, that it wouldn't make him feel bad, make him feel that he was not smart for also believing in traditional medicine. In addition to delayed engagement in care and treatment, there's also aspects of culture that prevent or impact adherence to particular regimens, adherence to particular protective behaviors. There are also drug interactions with Chinese medicine or other types of herbal roots that may seriously have a reaction with Western medicines. And if you're not respectful to the patient who prescribes to these other health beliefs, they might not share it with you. Conflicting messages, and unfortunately, morbidity and death as a result. Cross-cultural communication is key. It's one of the reasons why I decided to be a medical and linguistic anthropologist. I understood that there are different communicative styles, different norms and practices with cultural communities. Sometimes it can be, particular styles of talking, either being really expressive and collaborative, or maybe being, quiet, avoiding, and conscientious. But the one thing that I want to mention at this particular point is that communication is a process. Just because you say something to someone does not necessarily mean that that message was interpreted by your interlocutor the same way. So we always have to be aware that sort of in our cross-cultural communication, there could be misfires. And sometimes these misfires can result in cultural misunderstandings. So I love this quote. I know you believe you understand what you think I said, but I'm not sure you realize that what you heard is not what I meant. So, cultures have a lot of different standards for speech and communication. And these are things that we might also need to be cognizant of. Some communities speak really loud. They just talk really loud. I think half of my family is part of the loud speakers. And some communities are quiet. Some communities speak really fast. It's almost, you know, a source of pride to be able to speak that fast. There are a lot of Brooklyn folks who enjoy speaking very, very fast. And then some speak slowly. For some, that might annoy people. Like, why are you speaking so slow? But they're being thoughtful. They're measuring their words. Some communities use silence. Silence can say a lot. There's also attentiveness. In some communities, it's not polite to look at people straight in the eyes. You want to avert your eyes, especially if you're talking to someone of a different sex. Response time. My French husband might take several minutes after I ask a question because he's thinking. And sometimes that would frustrate me, but I understand that that's also very cultural in France to have restraint of, I guess, both pen and tongue. Turn taking. This is absolutely one of the places that we see cross-cultural miscommunication the most. And the fact that people have very different systems in terms of turn taking, and they're talking over to each other, and that's often indicative of different cultural expectations. Finally, there are ways in language that can also reflect respect and honor for our older adults. In Japan, there are these honorifics that are embedded literally in the language. And then there's elder speak, a particular register of talking to older adults that infantilize. And for many older adults, makes them feel like they're being babied. There are also negative impacts of culture that can affect our interactions, especially in clinical care. There are unacceptable symbols like the Confederate flag, swastikas, crosses, or other offensive symbols or tattoos or body piercings. There was a young medical student I met years ago who had a wonderful mohawk. It was great. I was so happy to see his little mohawk. But after he graduated, he cut his mohawk into a lovely little faux hawk because he understood that most people did not understand his hairstyle choice. There's language with negative overtones. And some people are really unaware that this language carries these negative overtones. So they might hear, people saying you people or boy and not understand how racially loaded those terms are. Finally, I really try to advise everybody not to engage in telling jokes because often they don't translate really well in across cultures. There are some people that absolutely are successful at doing it, but within the healthcare system, this is really something I discourage. So I want to just highlight these two pictures because I know they're really shocking and despicable. One is a gentleman who was working at an election polling place in Mississippi. And you can imagine how uncomfortable they would feel going in to say that they wanted to vote with this Mississippi justice. a noose hanging on his t-shirt. And then finally, I think about this wonderful picture of a Klansman who was seriously wounded and taken to an emergency room, and everybody working to save his life is Black. They put aside how offensive his uniform was. Their job was to be a healer. So sometimes we have to think about what's offensive, but what could be offensive from our side. And sometimes we have to put aside what's offensive from the patients. Ageism alert to our little dab. So we've talked about age being sort of very visible, and something that, you know, people are immediately labeled as being young, old, etc. But the truth is that within each generational cohort, there's also culture. Within our cohorts, we grow up exposed to the same historical events or changes in society that have an impact on who we are and how we see the world. And so the thing here that I really want you to remember is that these generalizations about our cohorts, about Gen X versus Gen Y or the boomers, is that they help us understand what they lived through and how that may have impacted them, but they're not monolithic groups. Just like culture, a cultural group is not monolithic. And so these can maybe be guides, but we should never sort of elevate them to being a truism, to a stereotype. I want to talk to you about the brain's negativity bias. And this also intersects with ageism. So often people, you know, they could be committed to diversity, but maybe they had one negative experience in their life and they still hold on to it. This is called mental residue. We hold on to negative experiences like Velcro. They just stick and stay. But those good experiences, they just slide off the pan, off the Teflon. So next, what I'd like to do is I'd love to show you this incredible video that I hope will help you think about what you think of older adults. Basically, the key to addressing all of these negative images, or maybe your experience has only been in the hospital seeing older adults, and so you think that all older adults are frail and sick and complicated. Maybe what you need to do is you need to focus on having more positive experiences with older adults. So I'm going to pause and set this video.
You can stand right there. That's her mark. How you doing?
I'm great. How are you?
Great.
Awesome.
Just tell us your first name and your names.
My real age?
My name is Paolo. I'm 25 years old.
My name is Daniela, and I'm 19.
24. 35.
31. 33.
I'm 26 years old.
What age do you consider to be old?
Late 40s.
Maybe 50.
I feel like 30 is a new 20, so I'd say like 40 is old. I'd probably say 50s.
I'd like you to show me how an old person would cross the street. Show me how an old person would send a text message. How might an old person do a push-up? What about jumping jacks? Okay, hang on. There's someone I want you to meet.
Hello, I'm Birch. I'm 66.
Hi, I'm Daphne, and I'm 68.
I'm Dee, and I'm 55.
George Fassbinder, 75.
My name's Parvati. I'm 70.
Nice to meet you.
Nice to meet you.
We're gonna give you about 2 minutes to teach each other something that you are good at.
I can teach you a jump that I do.
Okay, please.
Both of your legs go up, and your arm goes up, and your left arm goes like to the side. Ready?
Okay.
1, 2, 3. Lift 1, 2, 3. And bring it to your heart. And bring it to your heart. And the head in. Yeah.
I'm gonna try to get your balance and raise up. Now, you can bring your legs and your feet up. It's hard, right?
Yeah.
1, 2, 3, 5, 6, 7. So when you come out of a turn, either way, you go back to that basics.
Over. Now forward. Over. Yeah.
Square like this, and knee lock. Hook, jab, cross, hook, and then we'll go like this, all right?
1, 2, 3.
Now, what age might you consider to be old?
Probably 80 or 90. He could just do everything that I told him to do. An age that I would consider to be old now might be 100.
Do you remember what you said?
Yeah, I said in the 50s, I thought that would be old. But when I thought about it, like,
Wait a minute.
I'm sorry.
It really changed my thinking of what old is. You've taught me something today. Clearly, there's no way she's old, you know?
Now I know from today, hey, I don't look at age.
At my age, I feel like I did when I was in my 20s.
There's so many things that I still want to do. There's so many things that I can do. As long as I'm growing and learning, then age doesn't matter.
When people start stopping, that's when they start getting old.
Thank you. Thank you so much. Thanks, Daphne.
It was great meeting you.
How long have you been doing this? Is this a new skill?
40 years.
That was such an amazing video. I really love that, to be able to see these individuals have an opportunity to have new positive experience with older adults and to challenge their ageist assumptions about what an older adult can do or cannot do. And that's part of a campaign by AARP in terms of age matters. It's really a wonderful campaign. So understanding culture is really important to understanding how we should use the 4 M's to help our older adults. It can help us discover what really matters and motivates people. And it can also help us identify cultural barriers or facilitators that can help with medication adherence, mentation, or mobility. So this couple here might really love going and doing their salsa, and that's what they need to do culturally, socially, to feel that they're connected to their community. And so that would be a goal that we would aspire to work on in terms of maintaining or helping them with their physical ability, wherever it is. Now, I'd like to define cultural humility. Again, I want you to look at these questions and maybe pause the video and think about, what is cultural humility? Like, Why is it important to care and treatment? And what happens if I make a mistake? FYI, nothing. There are no mistakes. We're all learning in process. So cultural humility has been defined as a lifelong process of self-reflection and self-critique. Those are the two main components of cultural humility. That we use this reflection and critique to understand our own personal biases, and so that we develop and maintain mutual respectful partnerships based on mutual respect. So as C.S. Lewis said, humility is not thinking less of yourself, it is thinking of yourself less. Or Emile wrote, there is no respect for others without humility in oneself. Cultural competence has been described or defined as an ongoing process by which individuals and systems respond respectfully and effectively to people of all cultures, language, classes, races, sex, ethnicities, backgrounds, sexual orientation, abilities, and other aspects of diversity in a manner that recognizes and affirms and values the worth of individuals, families, and communities. And and above all, to preserve the dignity and their respect. So I have been a little bit troubled by the fact that sort of there's this construction of these false dichotomies that somehow cultural competence is the old way and that it's archaic and it's not open, and cultural humility is the new kid on the block. The truth is, I think that they are doing very different things, and you need them both in order to be truly culturally humble and culturally competent. So cultural humility, again, really is about the self, the introspection and self-critique. Both say that there are lifelong processes, but something within sort of cultural humility is this notion that it's impossible for us to be adequately knowledgeable about cultures other than our own. And as an anthropologist, I don't really agree with that, because that's the nature of my profession, of my discipline, is that, there's a science to understanding and learning about different cultural communities, whether it's through our ethnographic method, through immersion, through living in the field for many, many years, learning the language, that I wouldn't say that all anthropologists have perfect knowledge and understanding, but that we are always in this comparative mode in terms of trying to understand how their system might work in comparison to ours. So there is a little bit of self-critique, but it's not impossible to learn if you want to learn. The other side is that, people preferring cultural humility to cultural competence sort of say that, well, cultural competence is just like opening a book and just learning some aspects of culture, and that's all you need. And that's not true as well. There is no final stage in cultural competence. You don't finish a course and then you get a degree. Both take our entire lives to hone and develop our humility and our competence. I like to think of them as being two sides of the same coin. What we know in terms of healthcare is that having cultural humility and cultural competence together can lead to improved teaching and learning, diagnostic accuracy, patient and clinician or provider satisfaction, teamwork, collaboration, and morale. And it can also, if you are not humble and are not competent around culture, can lead to grievances, complaints, lost revenue, and litigation, and just not a really good working environment. One of those things that often happens in terms of culture in a work environment or in any environment that can be that can hurt are called microaggressions. There's nothing micro about microaggressions. They hurt. They feel like you've been punched in the gut. They're not small at all. They've been described as being brief and commonplace, which I would disagree with, but they can be verbal and behavioral and environmental indignities, like that man wearing that Mississippi Justice t-shirt, or people hanging up the Confederate flag or a swastika. Whether intentional or unintentional, these microaggressions communicate hostility, derogatory or negative slights, invalidations of our humanity, just because of our marginalized status in society. So now I would like to pause and share another video with you. If I can figure out how to pause here. There we go.
For people who still don't think that microaggressions are a problem,
Oh, you're so well spoken.
oh, just imagine instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland.
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins name. It's part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Can be shopping at
So
I
bad.
live here too.
And getting bit by mosquitoes every goddamn day,
Can I touch your hair?
multiple times a day,
So pretty.
Can I touch it?
Hair?
Please? Can I?
is fucking annoying. And makes you want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares?
Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try this challenging major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
It looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
I love that video, and I apologize for the expletive. My mother refuses to use it because of that one expletive, but I think it's such a wonderful video to highlight how the constant sort of assault of these slights, these little microaggressions, can take a toll on people of color. And so please forgive the expletive. So now I'd like to talk to you about stages of learning and the impact of bias. Again, I want you to pause and I want you to think, what do you know about cultural humility? And how would one go about learning cultural humility? And what does bias have to do with learning cultural humility? Let's check it out. The 4 stages of learning that were sort of kind of pioneered by Abraham Maslow and another educational scholar whose name escapes me right this second, but it's in the references, came up with these 4 stages of learning. And these are so appropriate for learning about cultural humility and competence. So this is a framework for how we learn. There's unconscious incompetence, which means you don't know that you don't know. You're unaware that you do not know what you're talking about. And then there's conscious incompetence, where you've suddenly become aware that you don't know what you're talking about. But personally, this is my favorite place to be in, because now you know that you don't know. And there's so much room to grow if you want to grow and learn how to be competent. Then you have conscious competence. So this is after you have spent time and to try to hone those skills to be competent, that you now know what you know. I know how to do it. I understand that now I've achieved some competency. And then the final stage, oops, I'm going the wrong direction, is unconscious competence. Unconscious competence, I often think about this as sort of being a metaphor for culture, because we are all competent in our cultural communities. For some of us, it might be really easy to outline what those boundaries are and what the norms are and what the practices are. But for most of us, it's unconscious. It just is what it is. It's how we've always lived and acted and behaved, and these are the things that are important to us. And it is what it is. Also, as we're learning cultural humility, when we move from conscious competence, it's when it becomes almost like secondhand, that we're no longer thinking anymore. We're just doing it. So to go back to the first stage, basically, I don't know, I'm completely clueless, I don't know that I don't know. This image of this surgeon with the book, Surgery for Dummies. But the truth is, often at this level, we find implicit bias. And implicit bias is described as the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So we're not aware of it. For example, arrogance, an arrogance to believe that, I can do surgery, or arrogance that that they are as smart and competent to understand what's going on with COVID-19 as Dr. Fauci. Biases can be both favorable and unfavorable, privileging one group over another. Assessments are activated involuntarily. Again, we're not aware of this without any sort of intentional control. Implicit biases can also coexist along with explicit egalitarian views and values. But if you have a brain, you have bias. The thing is, how do we learn about this implicit bias if we're unaware? And this is really the confounding nature. We all have them, all of us. Everybody has bias. But we're not necessarily always aware, okay? But they have an impact. They impact how we interact and engage with people, our behaviors. They're not accessible through introspection and self-critique. How do we find out about our implicit biases? They're seen in our behaviors. They're seen as blind spots. So when someone gives you some feedback, instead of just dismissing it, they're just being mean, think about it. When someone says, you don't really have a good bedside manner, or you were talking down to the patient, you don't look at the patient. Think about taking that moment to actually say, what's going on? And to try to understand. The first step to moving out of stage 1 and unconscious incompetence is awareness that you do have a bias. I love this picture because it's also, I believe, a really wonderful picture that captures also ageism in terms of what you prefer to see. Do you prefer to see the young woman with the beautiful neck? Or do you go to the older crone woman because you might value one more than the other or not value? Explicit bias, operates on a conscious level. We know it. We know it. Often emerges when people feel a threat. And it can be scary when you are confronted with conscious, explicit bias. Racism, expressed, is conscious and it's explicit for most people. Some are still unaware, but we'll help them. Confirmation or confirmatory bias is another type of bias that is it's a weird mixture of being aware and unaware. So you basically are looking for evidence, to support, confirm your beliefs or hypotheses while giving less attention to alternatives. It's difficult to have confirmation bias and be a scientist in terms of really being open to the null hypotheses and maybe not finding a difference. Then you have cognitive dissonance. This is a very strange bias, and it's a hard place to stay for a long time. In fact, you can't maintain cognitive dissonance forever. It is an uncomfortable feeling when you're holding two contradictory or conflicting beliefs. And the remedy is sort of ultimately, you're going to have to reconcile that you are pro-life, but you want to go kill some people. And so that is a serious cognitive dissonance. So for some, they don't want to go see the inconvenient truth. They really want to prefer a reassuring lie. So how do we move from unconscious incompetence to conscious incompetent? Awareness, insight, and really listening to feedback. Stage 2, conscious incompetence. I know that I don't know. Great place to be. And so there's a fork in the road because there's some people who they don't care. They're just like, whatever. I know. I'm not interested in learning. I don't care. And those folks are stuck. But if you do care about not knowing and not understanding, then you're on your road to moving through this stage of learning. Coming back to ageism, ageism can be implicit. Healthcare trainees often, are exposed to persistent misconceptions that older patients are demented and frail and somehow unsalvageable. This is an old person, or if you want to use the more technical term, a bed blocker. In a really important study, there was this particular quote that really reminds me of a moment in New York City during the first wave of COVID, when NYU decided that they might not give ventilators to older adults. And it was a real moment of ageism and value, that suddenly our older adults' lives didn't matter as much. It's always a bigger save when you can help a 35-year-old woman with kids than it is to bring an altered 89-year-old with urinary tract infection back to her semi-altered state. Sometimes bias can be explicit. To also work on changing, we need to practice. So it's too late at night for my little assistant to come and help me. But what I want you to do is I want you to try to say the color, not the word. So red, green, blue, yellow, pink, orange, blue, green, blue, white, green, yellow, orange, blue, white, brown, red, blue, yellow, green, pink, yellow, green, blue, red. Now, try to say the color and not the word. Green, yellow, white, pink, orange, blue, red, yellow, green, blue, red, blue, green, red, pink, blue, yellow, pink, green, orange, red, blue, orange, red, green. Takes a longer time because you have to really think and unlearn what you learned before. So don't practice until you get it right. Practice until you can't get it wrong. So, moving from conscious incompetence to conscious competent requires skill building, practice, and being open to more feedback. The third stage of learning is basically developing competence. Like, I know, I now know I've been working at this institution for a long time. It's taken me a long time, but I think I've learned how to be a better provider to the patients and the community in Flatbush because I've listened. I've made my mistakes. I know now what to say, how to say it. And I'm trying to be as humble and respectful as possible. Sure, I still make mistakes, but I practice. I practice every day. So now, as another sort of step along the way in terms of honing your competence, is also understanding that our intention is not necessarily the impact that is received. It's kind of very similar to what we were talking about in terms of language, that we might intend to say something, or also it's like the microaggressions. We might intend to be supportive, but our behavior, lands a different way. So yes, we might judge ourselves by our intention, what's in our heart to help, to compliment, or to do whatever. But the truth is, we have to understand that how the impact lands, that we're responsible for that. And that is ultimately how we're going to be judged. And we can't be dismissive and say, well, that wasn't my intention. It's a moment to stop and say, I'm sorry. I won't do that again. Because I don't want to hurt your feelings. I don't want to be disrespectful. I'm going to call you by, your name, Mr. Smith, and not call you Bobby. Because that's disrespectful to call an older adult by his first name. So, what do we do? How do we move from conscious competence to unconscious competence? Same stuff. We practice, we practice, we practice. And we get feedback. And we're open and willing to change our approach so that we can be more humble and more competent. Last stage. I don't even think about it anymore. I just do it. And this is the stage where we achieve humility and appreciation for change. But we're not done. We're never done. I've been doing this work for over 25 years, and every day I learn something new. I'm married to a person from another country. He's an immigrant, speaks another language. Every day of my life are cross-cultural communication misfires. Every day. And every day I'm challenged to learn more. You're never done. We are constantly learning the next level. So maybe in some areas, maybe you can move from being unconscious competent to other areas where you now know that you are incompetent. And that's how it works. We're constantly peeling back the layers, and there's never an end. There's no graduation. So, what type of competence do you think this is? It's a magician walking down the street and he sees a hat. And voila, there's a bunny. But did he really look at the person holding the hat? Did he really want a bunny? Or was he looking for some help? So was he unconsciously incompetent? Was he unconsciously competent? It was just he saw a hat, immediately, voila, a bunny. You decide. Where is he in the competence level? So now I want to talk to you about enhancement tools to hone your intra and interpersonal humility and competence. The first model is called Kaleidoscope. It's a diversity identity model. And remember at the very beginning, we talked about culture. And what does culture do? It helps us in terms of developing our sense of who we are, our identity. This particular model was developed by Marie Amy Taylor, who happens to be my mother, who has been working in this field for over 50 some years. She's taught me everything I know about cultural humility and competence. So there are 3 steps in her model. Number 1, we each possess a diversity identity profile. And this profile, built up over years and different experiences, is as unique as our DNA. No one really quite has our diversity identity profile. Number 2, diversity dimensions vary in their dominance or importance. Sometimes they even shift and flex depending on where we are. Our personal diversity identity profile informs and influences how we view the world around us and how we treat others, both consciously and unconsciously. So, what dimensions are most important for you? I want you to stop, pause, and think. What are my primary dimensions? What are my secondary dimensions? And what is she talking about? Dimensions that are contextual. So for me, just like this image on the left with this woman with all of her different roles, being boss, daughter, soccer mom, a lawyer, a wife, a neighbor, an aunt, a consumer, a coach, wearing a lot of hats. Mostly those are roles. But a primary dimension for me is that I'm a Black woman. I am an African American woman, meaning that my ancestors were brought here by force. I say that because we live in Brooklyn, and not all Black people here in Brooklyn are African American. The majority of the Black people here are African Caribbean. One of the things that I learned when I moved here, to be very careful of labeling everybody as African American. So for me, my race, my color, my gender, these are primary for me as a Black woman, my intersectionalities. What are my secondary? Could it be a birth order? Could it be a professional identity? For me, absolutely. I can absolutely at particular moments be the medical anthropologist. Or I could be the Philadelphian. I'm born in Philly. I'm a Philly girl. It could be your occupation. It could be a particular role that you fulfill in your professional life. What does it mean that you have contextual dimensions? Well, a lot of us never quite really feel American until we leave America and then realize how American we are. And then also, the context could be in one of these different roles. So I can be a professor at SUNY Downstate, and then I take my son to a soccer match, and I'm a soccer mom. Or being on the PTA, I'm in the PTA. And so I don't necessarily talk about my position or my discipline or my training, or sometimes my race and ethnicity, or my race, my color, or my gender. I could be surrounded by a bunch of Black women at the PTA. I'm not. But the truth is, these shift in terms of what's primary and what's secondary, or even tertiary, depending sometimes on the context. So I want you to think, pause again. Which dimensions are primary for you? Your race, your ethnicity, your language, your religion, where you were born, where you grew up, who you love. Think about it. All of those wonderful things, both on the surface and underneath. Okay? And finally, when we're thinking about our identity profile, we also have to remember that we have privilege. Privilege to be able to study, to be a healthcare provider. Privilege. But not all of us share the same type of privilege. So if you don't have to think about your race, your nationality, your language skills, your ability to speak English well, you have privilege. If you don't have to think about your spiritual, religious, or political beliefs, or lack thereof, you have privilege. If you don't have to think about the negative treatment you may receive because of the way you look, you have privilege. If you don't have to think about how others might treat you related to your sex, your gender identity, or orientation, you have privilege. And if you don't have to worry or think about the treatment you might receive in an emergency room or by any law enforcement official, you have privilege. Privilege is when you think something is not a problem because it's not a problem to you. And we always have to think about our privilege and understand that others' problems might not be our problems, but they're problems and they need to be resolved. Oops, my picture is covering up the next model, which is called emotional intelligence. This is such a very simple and elegant enhancement tool. Basically, emotional intelligence is the ability to manage yourself and your relationships. It was developed by Daniel Goldman, and there's this book. So I love that. It's very simple. Manage yourself and your relationships. As healthcare providers, you need to manage yourself, what's going on inside, your intrapersonal competence. And you also need to manage your interactions with others, your colleagues, the people you're trying to help. So in this model, on the intrapersonal side, we need to have self-awareness. I don't know what I should know. And then we also have to manage or do self-management regulation in terms of our feelings, whether we're going to be dismissive or arrogant. It's not important. I don't need to know that. Our anger, our embarrassment. Interpersonal is about social awareness. Are you paying attention to what's going on as you're talking to this person? Are you paying attention to their body language, their eyes? Are they sharing everything with you? Do you feel that they're not looking you in the eyes as they're talking? Something's wrong. I don't know what it is, but something's wrong. And then managing that relationship. How can I break through? How can I get this person to open up to me? Maybe it's something as simple as seeing your pediatrician and in walks a woman who says, I am not vaccinating my child. But yet they're wearing a little talisman on their wrist. And maybe in that moment, it's about I understand that you believe that there are things that you can do to protect your child. I do too. And maybe making a connection between that talisman and the vaccine to help get that child vaccinated. This is, I feel like, in terms of the two different sides of the coin, the self-awareness and self-management is in the definition of cultural humility, right? In terms of introspection and self-critique. And then with the older definition of cultural competence, it's very much about paying attention to what is in front of you, making sure that you understand what are the norms, what are the practices, so that you recognize them. You recognize that the silence is not good, that you recognize that turning away and not looking at me is not a good sign that they feel comfortable with me. So what do I need to do to get them to share what's going on? I love this quote by Eleanor Roosevelt, which to me embodies the emotional intelligence model. I didn't mention this, but obviously emotional intelligence has nothing to do with IQ. Nothing. You can be as smart as you can be, brilliant, a genius, and you could be emotionally unintelligent. To be emotionally intelligent is to handle yourself. To handle yourself, you use your head, but to handle others, you use your heart, your empathy, your ability to put yourself in that person's shoes, to understand what is their reality, what are their problems. And finally, the last enhancement tool is the implicit association test, which I've asked everybody to take prior to doing this SLM. This is a wonderful way to get a sense of where you are in terms of your bias. And there are different modules. So please, absolutely, do the one on aging, but also do the one on race and on gender. These are tools that can help you and help you understand, what are my blind spots? What are Tonya's strategies? Here they are, my top 10. Suggestion number 1, always acknowledge that there are cultural differences that exist and that these differences can prevent challenges and difficulties, okay? So always be on the lookout. But the other thing is that you've got to start with yourself and recognize that you have culture. So often providers walk into the room and they see the patient and they just think that the patient is the culture. It's not just the patient embodying the culture. It's you as well. And also, it's the room. The room is symbol of the culture of biomedicine, Western medicine, with the particular tables and I can't remember what the thing is that we put down on the things that people lie down, the paper, the way that people are dressed, the white coat, the stethoscope, the scrubs. These are all props in the culture of Western medicine. So first start with self. Think about your culture and think about how your culture impacts the care that you can provide. Own it. If you are consciously incompetent, you own it. You own your bias. You manage those tendencies to judge and assume and behave consciously incompetent. Now that you're aware, there's only one step to go. You go towards learning how to be more competent. You recognize, I have a blind spot. Number 2, a worldview is so impactful. As you're looking at yourself, really think about the worldview growing up in Philadelphia. Well, actually, I should say, being born in Texas on an Air Force base, growing up in Philadelphia, living in Europe and in Africa and South America, and then living in Brooklyn and marrying a French man and having little biracial babies. You assess the impact of your worldview, including all those things that you probably never think about: time orientation, space, notions of power, communication styles, personal beliefs. And you really, really look at how they might have an impact on care and treatment. Can I use them to help facilitate and to really be able to develop a rapport with the patient? Or are they barriers that are basically making everyone think I have horrible bedside manner? One thing that I want to say in terms of worldview is that we need to be very careful not to be ethnocentric. This is a big anthropology word that I love. And ethnocentrism is basically assuming that everyone is playing with your deck of cards, the same deck of cards that you play with, and that you guys are all playing in the same way, that we're all operating with the same social and cultural rules. That's ethnocentrism. To impose your views or your thoughts of how things should be on others is being ethnocentric. Even if it's a little slight, just assuming that someone might be heterosexual, or that because they're educated, they might do something differently. Okay? Ethnocentrism is never, never good if we, in a multicultural society where we celebrate all of our differences, no one's playing with the same deck. No one's playing the same game. Suggestion number 3. I love this. The cartoon says, you're deliberately putting yourself at risk of ill health by being over 65. Meet people where they are, not where you are or where you want them to be. Meet them where they are. Okay? So we all know, maybe not all, but there's this rule called the golden rule, to treat others the way I want to be treated. Right? Or it's a biblical thing, to do unto others as you would have them do unto you. But by practicing the golden rule, you're assuming that others want to be treated the same way that you want to be treated. Maybe not. So I want to show you the platinum rule. Okay? Do unto others as they would like to have you do unto them. Basically, treat others the way they want to be treated, not the way you want to treat them, but the way they want to be treated. Suggestion number 4. It's all about language. Learning how to ask culturally sensitive questions. Often when I was traveling in South America, people would just come up, not even ask permission, and touch my hair. And so I spent a lot of time trying to teach people how to ask that culturally sensitive question. Can I ask about your hair? How do you do your hair? And when we do this, learning how to ask culturally sensitive questions, we need to really work on listening and watching, using these models. We mirror these models and we flex, meaning that we're going to be flexible, that we're going to improvise, that we're not going to be rigid and static. We want to solicit feedback on our blind spots. We want to have these crucial conversations with people. So like, tell me, how was I really? Was I totally a jerk? You want that. You want to know so that you can do better. And when possible, provide that culturally sensitive feedback. Number 5, increase your ability to empathize. I feel like in our business of providing care, that this is core. It's core. But seldom does it ever really happen with our older adults. There's, a moving away. Older adults are touched less than any age group. They want to be touched. They want to be held. They want to be recognized. We will all age. We will all be an older adult one day. We all had older adults in our lives, if we're lucky. And to be able to bring that to your experience in terms of taking care of someone is really important. So I love this cartoon with this doctor, and he's wearing sort of the patient's the patient's dress, showing his little derriere. I think you'll find I'm one of the most empathetic doctors around. I love that. Empathy is seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. And then finally, use your emotional intelligence to stretch your comfort zone. I wonder if I actually have 10. I might have 6. Oh, I do. I cut it down to 6. Sorry. Thank you so much. And here's my email. And I will hope to see you soon. And we can talk more about cultural humility and how to be humble and competent as a healthcare provider. Thank you.